All right, well, hello everybody. Thank you so much for having me. This has been an amazing couple of days. Thank you for sticking around as well. So yes, as Peter was saying, some of you in the room, develop all these incredible tools, and then some of us mortals go and use it for other things. So I'm just going to show you a little example of how I do that. So for anybody who doesn't know where Exeter is, we are in the southwest of England, and we're in the middle of the countryside. We're surrounded by nature, by greenery. And I'm not sure if that's why some of us, well, in fact, a lot of us have become a little bit obsessed on how nature can actually affect, in a good way, in a positive way, mental health. And in my case, in particular, chronic pain. And we know that chronic pain is a growing issue. It costs the UK every year approximately £20 billion in loss of resources alone. So perhaps because of that, some clinicians now are trying to move towards green social prescribing and the use of nature as part of self-management therapy. So people are just sending these patients to nature and trying to interact with nature. And it has a lot of benefits for mental health. Reduces stress, anxiety, improves mood, etc., etc. But also we are starting to see that nature can actually can actually cause pain relief. But it's very variable. Some people respond really well to nature, and some people doesn't respond as well when it comes to pain specifically. And we don't really know what drives that variability. So we've been doing increasing more and more work to try to understand what are the mechanisms of nature-based analgesia. But you might already start imagining what are the challenges that come with studying the effects of nature inside of an MRI scanner, for example. We have some evidence that shows that nature might actually target some areas that have to do with endogenous pain analgesia. So just all these different pathways that we have in the brain that can elicit analgesia in a natural way. But these strategies have been descriptive for the most part. So essentially, people would put people in the scanner and show them images of nature and see what happens and what changes, or do some sort of pain task inside of the scanner while they're showing or where they're presenting them with nature sounds. But I think that it doesn't escape to anybody that this differs greatly to the actual experience of being immersed in a nature environment. So, the translational value of all of this is limited. On the other hand, people have gone really bold and really naturalistic, and what they've done is put people in a scanner and collect a series of measures and then actually take them for a walk in nature and then come back and then scan them again. And then you might imagine what of an experimental nightmare this is, because you have little to no experimental control about what's going on. So, again, the interpretability of that is limited. However, virtual reality came to save us from this nightmare because it provides a control platform to study nature-based analgesia within a naturalistic yet controlled way. So we can actually immerse people in this environment, know exactly that the same thing has been presented to everybody, and we can do things at the same time and preserve all this experimental control. And although we are using it more and more, we still don't really have a clear neurophysiological model of how nature-based analgesia works. So there's still a lot of work to be done. And with that in mind, I'm going to talk about a study that we just did that is very, very fresh off the oven. And made it to the cover. So if anybody reads pain, which if you do any pain studies, probably you do, then this is what it looks like this month. And we had two main questions that we wanted to address. And the first one is, well, first of all, can immersion in nature delivered through VR induce pain relief over non-immersive exposure to nature, which is what has been used before, for instance, in the scanner? And the second question is, can we gain some mechanistic understanding for this effect? And this is where DCM is going to come in handy, which I'm going to talk about on the second part of the talk. But first of all, well, we need a model of chronic pain. And of course, we could take chronic pain patients and we can, do this study with them specifically. But we know that people with chronic pain will have other types of issues that might, interact in various different ways with the extent of pain relief that they might be able to experience. So we really what we want to do first is recruit healthy participants and use a model of chronic pain. In my case, or in our case, the model that we use frequently in our lab and it works pretty well is the high frequency stimulation model. So what we do is collect baseline pain sensitivity measures using like instruments that we use routinely in the lab, quantitative sensory testing. So we just prick people in like different parts of the forum and just ask them for a simple rating of how painful they think that is. And then we electrocute their arms. So we deliver electrical stimulation, like 5 short pulses of electrical stimulation to the arm, which is admittedly not fun, but is very short lasting. And what happens after that is that people will develop sensitivity around the area where the electrode was placed and mimics really well neuropathic-like symptoms. It lasts for a couple of hours and then it disappears and then the person is completely fine, which gives us a nice window of a couple of hours to try to modulate this effect in one way or another. So now I'm going to talk to you about what the experimental design was and what happened in each one of the first 3 sessions that we did. So people would attend the lab and then we would collect these mechanical pain sensitivity measures, then do HFS, electrical stimulation, and then we would collect mechanical pain sensitivity measures again, 15 minutes, 35 minutes, and 50 minutes after manipulation. In one of the sessions, there would be no intervention other than this, so people would just wait for the next measurement. In another session, for the first 40 minutes, people had a VR headset on and they were immersed in a nature scene. There was real footage of the nature scenes while we were doing this. And on the sham VR condition, people would be exposed to these nature scenes, but in a 2D screen, which was still nice. So they were in a dim, like in a dark room, there was quiet, they were watching all these nature scenes, but it was not immersive as if it was not 360. And you might be wondering where brain scans come into play. So we had another session where participants attended an MRI scanner and we collected a resting state MRI endpoints during a tonic pain stimulation tasks, which essentially was immersing their hand in cold gel, which is cutting edge technology, with water, cornstarch, and salt put in the fridge. But that works pretty well, and that actually elicits tonic pain for the 6 minutes, the duration of the scan. So now how I'm going to put all of this together. So the idea here is that if nature immersion is thought to engage these endogenous pain modulatory pathways, and this is an example of what they look like, and they're like the usual suspects that would be involved in this like top-down endogenous pain modulation pathway. So sensory cortices, PFC, ACC, insula, hippocampus, hypothalamus, and like PAG and other brainstem regions. And we do have some data, and rest state data during tonic pain that provides a window into these circuits in action, because people would, automatically be able to engage these endogenous pain modulation pathways. Then perhaps we are able to use spectral DCM to model effective connectivity patterns that explain individual differences in nature based on analgesia. So if people are able to engage these pathways per se, then, and these are the same pathways that are being recruited by nature, then perhaps we can explain the relationship between these two. So first, I need to tell you, so that you believe me, what were the results about the first part of the experiment. So can immersion in nature delivered through VR induce pain relief over non-immersion exposure? So here you see some, the behavioral results. So the first set of graphs, what you see is what happened in the non-intervention condition. So essentially anything that goes over the 0 line means that there was pain sensitivity after HFS, and there was stable and consistent significant group increase in pain sensitivity, which means the model worked. So which we knew we would, but it did, which is great. The next, the font is a little bit small, but so the next set of box plots, what shows is what happened with the sham condition. And what we see is that at the very beginning, we no longer see a significant result. But as time goes on, we see that this pain sensitivity starts increasing again, which would fit within the idea of like maybe something that's distraction based. So they were initially sort of like distracted by the fact that they were liking the footage, and as time went on, and they go bored, and this pain sensitivity came back. However, in the VR condition, what we see is that there's no longer a significant result across all the different measurements, including the measurement at 50 minutes, where people have not had the VR headset on for a few minutes. So we see some long-lasting effect. However, as you might be able to see, there's great variability. So there's some people that still are quite sensitive afterwards. So we, again, see these variability in pain, in terms of pain relief, that we have already seen in patients before. Here I show you a different example of how we can measure this pain relief. So we systematically mapped this pain sensitivity radially from the electrode out. And then we can create heat maps of where this hypersensitivity is located around the electrode. And what we see is that in the no-intervention condition, again, we see a consistent moderate to severe hyperalgesia around the electrode. And this in the sham condition, and I'm not sure if you're able to see here, but the area has been significantly decreased and to some part at the bottom. But in the VR condition, there's no longer any areas that suffer from mild or to moderate hyperalgesia. So yes, we can induce pain relief using virtual reality over non-immersive exposure. But now the next thing that we need to ascertain is whether we can gain some mechanistic understanding for this effect. And this is where we use a spectral dynamic causal modeling. So essentially, we build a generative model with the usual suspects that we would see as part of these top-down endogenous pain analgesia pathways. And this is including the anterior insula, the dorsal ACC, the thalamus, and the PAG. I should say that the PAG actually did not look like that, was an anatomical mask, but for the sake of presentation, sorry for the little bit of deception there. And we just described, so we allowed the model to be fully connected, so we allow all the connections to be there. We have no prior, assume no prior knowledge of how these connections would work. So then these models get estimated for each person. So essentially, I know that a lot of people understand how dynamic causal modeling here is, but the idea here is that instead of looking for correlations in the whole signal across different areas, you are looking at fluctuations in the frequency domain, and that allows you to understand where the influences from some parts of the brain to another, in this case from one RI to another, and also the nature of this influence, whether it's excitatory or inhibitory. And you create parameters that you're going to end up with parameters for each one of these connections for each one of these individuals. However, we want to look at group results. So for this, we can use a framework developed by people in this group called parameter empirical base, which allow us to look at group effects of commonalities across all these different individuals. And it allows you to look for group effects in a similar way that you would do with your usual parametric statistics, which is something that's more intuitive for people like me, for example. And the particular effect that I was interested in, that we were interested in, is in the net VR effect. So essentially what you see in that column there, what is showing you is simply the difference in the amount of sensitivity that people had at 50 minutes in the baseline condition minus the VR condition. And also to simply understand what's the difference between those two. So what you see here is that high scores mean that there was more pain during VR, so nature did work. And lower scores means that there was less pain during VR, so nature did work. Here you see what the results were. So overall, the model was able to explain over 90% the variance of the data. And we did try to, simplify this using Bayesian model reduction, but there was not really an overall model that performed better than this. So now I want to drive your attention to the net VR effect. So I'm just showing the connections that had a posterior probability of over 0.95. So more 95 probability of being present versus being absent. And I guess here, if you are not in the field of pain, maybe you need to take my word for it. But what we're seeing here is that we have several different types of connection going up and down, inhibitory, excitatory. But what we see is quite a few connections that are top down and they are inhibitory, which would match really well with what we would expect to see in a case of top down descending pain control. But obviously now this needs to be validated. Everybody seems to validate these things in a slightly different way, I've noticed. What I did was canonical variant analysis and create a canonical variable that we could correlate with a behavioral measure, so our net VR effect that we actually understand. And I took the connection that had the highest load on this kind of resulting canonical variance, which was that one over there from the insula to the thalamus, and correlated with the net VR effect. And what we found is a modest but significant correlation between the strength of that connectivity, effective connectivity, and our VR effect. So in particular, less excitatory activity from the effective connectivity from the right insula to the thalamus correlated with a lower or like a less positive VR effect. So can we gain some mechanistic understanding for nature-based analgesia, which is something that, you know, like is traditionally so difficult to understand in a controlled way? Well, to me, my answer is yes. Obviously, this is not the end. There's still a lot of things that we need to do. The next step for us, the most obvious next step for us, is concurrent nature immersion and FMI or FMIR. So we do have some MR safe VR goggles that we are starting to use. There's still a lot of work that we need to do to know whether they induce the same amount of immersion than, you know, your traditional VR headsets, but you know, we have a lot of undergrads that are about to be really excited about looking into that for us. And obviously this, now we have sort of like a model that we can start building on, and we can start testing how this model really compares to what would happen if we use like patient cohorts, like of any sort. So that's another thing that we have in mind. And the third thing, once we have a really good understanding of how nature-based analgesia works and that we can actually deliver these effects through VR, then we can start using other techniques to try to maximize these effects on people that perhaps are not engaging these pathways that well. So for example, doing things like neuromodulation. And with that, that takes me to the end. Thank you so much for listening. And everything is available for the repository. And thank you to me.